All right, everybody, welcome to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight's talk is Diabetes, New Testing and Treatment for Retinopathy by Dr. Nate Lighthizer. He's a professor at the NSU College of Optometry in Oklahoma. He's a noted lecturer. He's a noted speaker. He's a noted writer. He has done hundreds, if not thousands, of lectures and trained numerous students and residents. It's been our great pleasure to work with him. He has lectured all around the world, and he has now recently been named Dean, Dean of the College of Optometry in Oklahoma. He's Chief of Specialty Care Clinics. I know we're going to have a great presentation, so Nate, please take it away.
Thank you, Joe. Appreciate that very kind introduction. Good evening, everybody. Hope you are all doing well wherever you're watching this webinar from. My name is Nate Lighthizer, again, faculty member at the Oklahoma College of Optometry. I want to thank Greg and I want to thank Joe for inviting me back to lecture for them once again, the Optometric Education Consultants. I really appreciate both of them, consider both of them great friends and really colleagues and mentors, people that I look up to. They have been just, at the forefront of education and lectures and really visionaries in optometric education and leaders in our space. So I appreciate both of you very, very much. Thank you for all that you guys do, and thank you for the invite. So I look forward to kind of discussing tonight and lecturing over the next hour and 40 minutes, and those guys moderating and us kind of throwing questions back and forth on diabetes, new testing and treatment for retinopathy. I'm located in Tahlequah, Oklahoma, at the Oklahoma College of Optometry. You guys may or may not know, we serve Cherokee Nation. We are the official eye care provider for Cherokee Nation. We have 11 locations in Northeast Oklahoma, and we serve about 99% of our patients are Native American. Most of them are Cherokee. So we see a lot of ocular pathology, a lot of systemic pathology with our patients. We see a lot of patients, about 45,000 patient encounters we have every year in our system. So we get to see a lot of disease, and we're very fortunate to have a scope of practice in Oklahoma, really at the leading edge, at the cutting edge. As we'll talk about in the next webinar in October, when I'm back with you guys again for laser procedures and talking about the latest and greatest in SLT, YAG, CAP. So make sure you join us for that one in mid-October. So tonight's diabetes, new testing and treatment for retinopathy. I'm going to take this with a little bit different slant on. We're all very familiar with diabetes. We've seen patients all the time that have diabetes and diabetic retinopathy. And we're going to talk this a little bit more on different testing, hence the new testing and new treatment for retinopathy, a little bit different way to look at this. I'm going to challenge you guys tonight to think about diabetes and diabetic retinopathy and how we manage those patients. Let's maybe do it a little bit differently than we've done it in the past. I know I do it differently now than I did even 5 to 10 years ago. So there's my disclosures. We will keep this within the guidelines of a COPE-approved lecture. And I'm not going to poll the audience tonight in terms of poll everywhere. If you've been to my lectures before, you know I often do poll everywhere, so don't worry about that. The only polling tonight will be the polls that Greg or Joe launch right here in the Zoom. So don't worry about going online or anything like that. Again, it's only going to be those 5 polling questions launched via Zoom. You'll see the questions when they come up. I'm going to show you some of the questions that I usually ask. Again, don't worry about answering this live. When I do this question or this lecture live, I often ask, do you think testing structure and function in our ocular pathology patients is important? And I will tell you that 100% of the time, I get 100% of you that say, yes, I think structure and function is important. This is something that we do very, very well all the time, and we'll get into that in just a little bit. I always like to show a picture of my kids. There's Addie and Camden. They are 12 and 9. So it's probably time for an updated picture. What do you think? 12 and 9. I probably need to update that slide. Here's the next slide from Disney. I threw this in for Greg and Joe. I don't know about Joe, but I know Greg is a Disney fanatic. I am a Disney fanatic. My wife and kids are Disney fanatics as well. Greg, have you been there recently? I think you guys have been there recently, haven't you, Greg?
We were there in June.
In June. Okay. Did you go to
Hmm.
Epcot?
I did not. I think Greg may have. I think we might have lost Greg with his hotel connection, but I'm sure he'll be back.
No,
Well,
I'm here. I'm here. I'm
Oh, okay.
good.
Oh, sorry.
have you been to
I'm
Epcot?
good.
Did you go? There's us at Disney World a couple of years back. You guys will get a kick out of
I
this.
have.
Okay.
That's
So
Magic Kingdom.
there's Magic Kingdom. We went in October of 22, not for business. It was all pleasure. My wife and I turned 40 in 2022, and we went for a week with her parents, her sister's family. It was just us having a good time for a week. No business. I wasn't lecturing. I've lectured for you guys in Orlando before. It was a great time. So it's day 6 of the trip, and I haven't seen anybody I know professionally for the first 5 days. And on day 6 of the trip at Hollywood Studios, my daughter asks me, she says, Daddy, can we paint our faces together? What am I supposed to tell my 10-year-old daughter? Of course I'm going to do that. So I figured you guys were going to pick a kick out of that picture right there. There we are with our faces painted. And I'll tell you, Greg, Joe, it wasn't 10 minutes after I had my face painted on day 6 of the trip where I had not seen anybody I knew the whole time. And I'm walking down Hollywood Studios and I hear, hey, Dr. Lighthizer. And my heart just sunk and went, oh, I just got my face painted a pirate, you know? And I turned around, it's a doctor from Idaho that I knew that just about fell over laughing. So I thought you guys would appreciate that story.
Yeah,
Uh,
that's a good
I'm
one. I
surprised
like
they
it.
recognize you with your face painted.
yeah, looks good, doesn't it?
Hmm.
Now, here's if you go to Disney, any Disney fanatics out there, you got to go to Epcot. And I bet, Greg, you've ridden Guardians of the Galaxy. Have you ridden that yet?
Oh, fantastic. Yes. At
Man,
least 6 times.
there, it is the most, if you like roller coasters, it is the most incredible roller coaster. There's my daughter right here, just loving life on Guardians. Here I was in the other one. You can see me in the top left there. This is so awesome. Note my son in the bottom left didn't think that was as good as we did. You can see, and he actually ripped chunks after we got off the ride. So,
Uh,
you know, oh, 7-year-olds didn't enjoy it as much, but pretty cool ride. If you ever get to Disney, Epcot, Guardians of the Galaxy, you got to check it out. Born and raised in North Dakota, as Greg said, and we're going to get on to business here. Our course outline and objective. We're going to talk on some new testing. Again, ERG, some color vision testing. We'll touch on OCT angiography. What can we do more than we have traditionally done for diabetes and diabetic retinopathy? I don't know about Joe and Greg, but in our clinic, I know I'm guilty of in the past. We took a look at the back of the eye. We did our DFE and did our OCT and we did our fundus photos. When you think about it, a DFE, fundus photos, and OCT is looking at structure, structure, and structure. And we certainly want to look at structure, but we do structure and function so very, very well in other conditions like glaucoma, macular degeneration, structure and function. How does it look? But also, how is it functioning as well? And I think our main ancillary test for diabetes has been OCT. Let's get a picture and let's take a look at the back of the eye. And again, that is structure, structure, structure. If all looks pretty good, there's no retinopathy or mild retinopathy, we'll see you in a year and we'll check you again. And we watch and we wait. We watch and we wait. We're watching roughly every year. We're waiting for hemorrhages. We're waiting for swelling. We're waiting for cotton wool spots. Is there more that we can do for diabetes and diabetic retinopathy other than watching and waiting? Watching and waiting. Can we be more proactive at this and guide patients in a better manner, follow them more closely? That's what we're going to talk about. And that's what I think functional testing really adds to the picture, whether it's ERG and or color vision, mix in OCT angiography with our OCT testing of it's not going to replace our OCT. It's not going to replace our fundus photo. It's not going to replace your DFE. It adds to it. It gives you a better picture of the entire puzzle of what's going on, similar to our cardiologist. Would you want to get a complete cardiac workup without an EKG? without getting structure and function, an angiogram, EKG, stress test, et cetera, you would want both structure and function. So I'm going to encourage you guys tonight to think about how can you add to your OCT, your fundus photos, your DFE with some of this newer testing that is available in your practice there. So structure, function, so very important. Joe, Greg, any comments on that?
No, I agree with you
The answer
very
is yes.
much.
I'm going to turn off my video because I'm
Yeah.
Yeah, I'm going to make a comment here. I'm going to turn off my video to help save some of the bandwidth here at the hotel. Nate, I'm just going to feed off of that and say, I agree 100%. You have OCT that most of us have, and it's testing structure. I see you have OCT angiography, which warms my heart because diabetes is a capillary disease. We can maybe see some of that capillary dropout, but can we pick up on diabetic retinopathy before OCT-A? B-scan OCT is good, but I think there's other things out there, and I'm looking forward to your lecture that's there. And I agree, structure and function need to work hand in hand here because we do it with some other diseases really well. I'm not sure if we do it the best, but that's why we come to continuing education to learn about that, and I'm looking forward to it.
Awesome. And then once you have that functional testing, once you have to pair with the structural testing, okay, we've got some changes. Anytime we incorporate new technology, whether it's structure or function, OCT, OCT-A, or ERG and color vision, what is it going to bring me? How is this going to change what I do? And I will give ways that this changes what we do. Maybe it's seeing the patient more often, additional testing, but we'll talk about nutritional supplementation for diabetes and diabetic retinopathy, go through some of the literature on that. We are all very well versed on nutritional supplementation in posterior segment disease with macular degeneration. I think we're less well versed and less experienced on diabetes and diabetic retinopathy. Let's go through that. And again, is there more that we can do than telling our patient, control your blood pressure, control your blood sugar, and I'll see you in a year? You ever had that on autopilot? I know I am guilty of that. Go, hey, Mrs. Jones, control your blood pressure, control your blood sugar, I'll see you back in a year. Let's be more proactive at that, and nutritional supplementation, I think, plays a role of that. So again, here's your structure, fundus photos. We've got beautiful cameras now that take pictures and document that retinopathy. Again, all of you, I want you to hear, you should continue to take photos, document very, very, very well, document that structure. What does the structure look like? And pair with it that function. The value of structure and function, they go hand in hand. And, does function precede structure? Does structure precede function? Depends on the study that you look at, depends on the data that you look at. If you go way back to Oates, 20 plus years ago, it said approximately 55% of patients had structural defects before visual field defects. About 35% had visual field defects before structural defects, and about 10% had both. So it depends on the case. It depends on the entity, whether it's function before structure or structure before function. And just due to that nature, we need both, and we need to emphasize both of those. So I'm going to start with electrophysiology. And what do you think of when you think of electrophysiology, ERGs, VEPs, multifocal ERGs, EOGs? Do you think of this? Oh man, I remember falling asleep second year of optometry school. It was, man, I don't even remember most of those lectures. VEPs, VERs, EOGs, multifocal ERGs, XYZs, who knows what it was. All I remember is there was wires in that room everywhere, and there were no windows, and you had to have it dark. And man, they put patches on what seemed like forever, dark adapting these patients forever. My point is this: electrophysiology today is very, very different from our grandfather's ERG or even our father's ERG from 20, 25 years ago. A test and testing that was mainly in the research center, maybe in an academic institution, maybe in a tertiary care retina practice, big center, something like that, Dallas, Kansas City, Salt Lake, except Boston, New York. Now this is becoming more and more mainstream in private practice optometry. And why is that? Well, it's because, nobody's going to want to do testing that looks like this, where you have electrodes, who knows where. We're doing hairs, you can see there. Here's one of my favorite pictures. I got this one off the internet. We are reading minds when it comes to ERGs. This is like 50 plus years ago. It was not patient friendly. It was not doctor friendly. It was not staff friendly. Joe, Greg, I remember I did my residency in Oklahoma in 2009, 2010. And right at the end of my residency, I was joining the faculty. And the chief of electrodiagnostics clinic was retiring. Well, I had no clinical experience with electrophysiology in my 4 years at Pacific. I'm sure we had some lectures on electrophysiology, electrodiagnostics, but I had zero clinical experience. Got down to Oklahoma, and during my residency, we have an electrodiagnostics clinic. We have an electrophysiology clinic that runs 1 day per week, still does, here at the Oklahoma College of Optometry. So during my residency, I spent 4 days in electrodiagnostics clinic, an electrophysiology clinic. Well, I finished my residency. I'm joining the faculty, and the chief of electrophysiologists happens to be retiring at the exact time that I'm joining the faculty. So they came to me and they said, Nate, we'd like to make you the chief of electrodiagnostics clinic. You've spent 4 days in electrophysiology clinic, and you must know everything you need to know about electrodiagnostics. We'd like to make you the chief of the clinic. And I remember laughing and chuckling and thinking they're just trying to give jobs away to new faculty, because they got to do that. But I'm really glad that I said yes, because it has completely evolved since 2010, how electrophysiology was done. In 2010, 11, 12, that clinic was filled with patients with cone dystrophies, retinitis pigmentosa, rod cone dystrophies, unexplained vision loss, Best disease, etc., etc. My point is, you're probably not going to have a piece of equipment in your office for your cone dystrophy patients, for your Best disease patients. We used to dark adapt patients. We had to dilate them, sit them in the dark for 30 to 45 minutes. They had 2 patches on. We had to put these huge electrodes on. It has completely evolved and changed in the last 10 to 15 years. The technologies went to very portable. The first instrument that we bought was $85,000. And now these devices are under $30,000. We have handheld devices now that you can take room to room to room to do these ERGs. So let's talk on electroretinograms, ERGs, and diabetic retinopathies. Another question, again, there's no polling here, so don't worry about that. Ignore the QR code in the top right. This is just a question I usually ask is, think about this. Your patient that's got no retinopathy or mild NPDR without macular edema most often has a visual acuity of what? Let's assume no cataracts. Let's assume no ocular surface disease. Your patient tomorrow morning, that's a long-standing diabetic, 10, 15 plus years, has mild NPDR, couple of microaneurysms, couple of little changes here and there, nothing major. What's their visual acuity usually? And when I ask this question to a live in-person audience, I will tell you 95+% answered 20/20. And I agree completely. No cataract, no ocular surface issues. Your mild NPDR patient is usually pretty darn close to 20/20 unless something else is reducing their vision. My point is this: visual acuity, if you're waiting for visual acuity to fall in diabetic retinopathy, we are waiting way too late. Visual acuity is something we have to do, but it is not the best metric for seeing how is my diabetic patient functioning. There are better ways to do that. So is this something that we are going to see more and more going forward? The answer is an obvious yes. We know that as the population is aging, as it's increasing, and we're getting more boomers in their 50s, 60s, 70s, 80s, we're going to be seeing more and more diabetic retinopathy. There are no ifs, ands, or buts about it. You can see the current stats from about a decade ago. It's going up and up and up. Pre-diabetes is going up. There's no ifs, ands, or buts about it. We are going to be seeing more diabetes and more diabetic retinopathy. Joe, Greg, we are going to be handling more glaucoma, more macular degeneration, more diabetes and diabetic retinopathy. Ophthalmology numbers are static. they're kind of stable, maybe even declining slightly. And we're almost going to be forced to manage more of this. Your guys' thoughts on that and really embracing the medical management of diabetes, diabetic retinopathy, glaucoma, AMD, lasers, etc.
I think one of the most exciting aspects of practice is being able to be full scope eye care. Refractive care, contact lenses. The next person comes in with a corneal infection. Next person comes in needing some help reading. Next person comes in with diabetes that needs to be monitored. The next person has glaucoma. Yeah, we're all sort of segueing into almost general ophthalmology, albeit with lesser surgery. So I think that we're going to be handling a lot more of this. The medical model is not, to me, it's not one or the other. It's not refractive care or medical care. It's really comprehensive care. So if we start getting more subspecialists and fewer general or comprehensive ophthalmologists, that's the role that optometry is going to be playing.
Yep. I completely agree. I completely agree. And I think it's in us to own every space that we do so very well. Diabetes and diabetic retinopathy. Again, the rate of diabetic retinopathy, if your patient comes in and says, I was just diagnosed with diabetes, I understand that the diabetes makes me more prone to have a heart attack, more prone to have a stroke. I can have kidney issues. I can have neuropathy. But I've also read that this can affect my eyes, doctor. I can develop this diabetic retinopathy. And I was reading about how likely is this going to affect my eyes. It's roughly about 1/3 of patients are going to develop diabetic retinopathy. But what does that depend on? Not every diabetic is created equally. Which patients are much more likely to develop diabetes and diabetic retinopathy? You and I know it's type 1 versus type 2. It's duration of disease. Generally speaking, which diabetic are you most concerned about? The 30-year diabetic or the 3-year diabetic? The longer they've had diabetes, we know duration of disease plays a role. Type of diabetes plays a role. How well they control their diabetes. Do they have a pretty stable blood sugar? What's the last hemoglobin A1C? How much fluctuations do they have? And other comorbidities as well. And so we know there's a lot of factors that play a role. But generally speaking, duration of disease plays a role in this. And we are more concerned when they've had diabetes a couple of decades versus a couple of years. I'm going to come back to that point near the end of this lecture. Proliferative retinopathy. About 1 in 13 patients develop proliferative diabetic retinopathy. And if they have proliferative retinopathy, they have went through all the stages of non-proliferative retinopathy. We've watched them go from no retinopathy to mild non-proliferative to moderate to severe and into proliferative. And again, I challenge you to think, is there more that we can do for our patients instead of just watching and waiting for them to progress with 1 in 13 patients getting to proliferative retinopathy, more prone to other conditions, increased risk of cataract, glaucoma, stroke, as we've talked about already, different severities of disease, as we just talked about. And this is a table from the American Academy of Ophthalmology, their preferred practice patterns from about 5 years ago. And I like this, just look at the initial management recommendations for patients with diabetes. And, you take a look. Most often, when you look at this, when you think of the top part of this table all the way to the bottom part of this table, okay, this table, what stages of disease, what half of the disease are we as optometrists more involved with? And the answer is going to be it's the top half. Most of my patients have no retinopathy, mild non-proliferative, or moderate non-proliferative retinopathy. Yes, we have patients that have severe. Yes, we have patients that go proliferative. But generally speaking, we are going to have way more patients in the first half of the disease versus the later half of the disease. That depends on the practice where you're at. But by the time they get to proliferative, they're usually in the hands of ophthalmology, retina specialists, et cetera, et cetera. So I think most of you would agree we're going to be hanging out in the top part of this table, the no retinopathy, mild retinopathy, and moderate retinopathy. And again, notice when you see these patients back, 12 months unless they have macular edema, and even moderate retinopathy, 6 to 12 months. So generally speaking, most of my patients, it's see you in a year. Do we need to reevaluate that? Do we need to rethink that every time you to see that patient, that is another touch point for education, to show them you care, to reemphasize key points on treatment, management, education, et cetera, et cetera. So remember that follow-up, and we'll come back to that in just a little bit. The flash flickering.
Hey, Nate, 1 second, real quick. Go back one, because I did put your polling questions in. I did get to put the survey questions in, so I saw your handout and where you're going. I love this slide here. And what I like to point out is to the audience and to the attendees and our colleagues is that this is also going from top to bottom, the amount of ischemia that this eye, in a sense, not totally, but think of it as another metric as you're grading the ischemia. Mild ischemia, moderate ischemia, severe ischemia. And then with that being said, you might not be seeing the structural changes. Is that ischemia now affecting the function of some of these tests that you're going to be talking about? So remember, diabetes, to the colleagues out there, it's a capillary disease. It's an ischemic disease. And when you look at this, okay, when you get down to non-proliferative, really ischemic, now you released VEGF to create the NEO to try and save this eye. So even though it says 12 months, is there more damage going on? And that's where Nate's going to go, I believe, with some of this function testing. So I just wanted to point that out.
Great point. Love that. And I love that you brought up the ischemia point. And we're going to emphasize that again and again and again going forward here with ERG. We can't let that silent ischemia go on and on and on until it's too late. And that's why we have to utilize this functional testing. So let's talk on the ERG. You know, there's different types of ERGs. There's multifocal ERGs. There's flash ERGs. There's pattern ERGs. The first word in that is important. Flicker or flash ERG, pattern ERG, multifocal ERG. It's telling you what the stimulus is. When somebody has a flash ERG or a flicker ERG, really the same thing. A flash ERG is a flash of light. Kind of like this. You're holding something up to the eyes, and it's flashing lights in the eyes, which obviously stimulates the retina. Well, let me give you a contrast to that. A pattern ERG. If you do a pattern ERG, the stimulus is a checkerboard pattern or a bar grading pattern on a computer screen, meaning the patient is looking at a computer screen. So if you're doing a pattern ERG and you're looking at a computer screen, all of you are looking at a computer screen right now. And when you're looking at that computer screen, the image on that computer screen is falling on your central retina. Okay. When you look at your computer screen right now, you can see the ceiling, you can see the floor, you can see the walls. But when you're looking at the computer screen, that image on the computer screen falls on your central retina. So when you're doing a pattern ERG, the bar gratings or the pattern is falling on your central retina. Here's the take-home point. Pattern ERGs, which we're not going to talk about tonight, pattern ERGs are more of a test of central retinal function. Multifocal ERGs are very similar because you look at a specific pattern that rotates around with a multifocal ERG used more in Plaquenil. This is the opposite. If I flash a light in Greg's eye or in Joe's eye, that light goes superior, inferior, nasal, temporal, central, peripheral. Flash ERGs are a test of overall global retinal function. How's the retina doing from top to bottom, left to right, superior, inferior, nasal, temporal? How is the retina functioning? A flash ERG may not pick up small retinal issues. A flash ERG is not the test of choice to pick up early Plaquenil toxicity, to pick up early hydroxychloroquine toxicity. We all familiar with the bullseye stage, but if you want to detect very small, subtle changes early in Plaquenil toxicity, the flash ERG would not be the test of choice. It would be OCT or fundus autofluorescence or multifocal ERG, maybe mix in visual field, et cetera, et cetera. Go ahead.
Yeah.
Oh, sorry. I thought I heard something.
No.
The flash ERG is an overall test because it's a flash of light that diffusely illuminates the entire retina. That's why this is an overall test of global retinal function. Well, which disease Do we want to know overall, how is the retina functioning? It's diabetes and diabetic retinopathy, up, down, left, right, superior, inferior, nasal, temporal. So remember that. Flash ERG, overall test. How's the retina functioning? Hopefully well. And we'll also know if it's not functioning well. So that's how that ERG works. Showing you this with pictures. Your best corrected visual acuity is tied very, very closely to that central point, that central 2 to 3 degrees. That's what best corrected visual acuity shows you. Let me give you a take-home point in a non-diabetic. This is a patient that I saw 4, 5, 6 years ago, and this patient was referred in for special testing. This is a 53-year-old female. 53-year-old female that was sent in for OCT, OCT angiography, ERG, again, special testing, figure out what's going on in the maculas of this 53-year-old female. Now, obviously, she's got extensive geographic changes in both eyes. One could maybe argue that looks a little bit kind of bullseye-ish. Has she been on hydroxychloroquine or Plaquenil for the last 30 plus years? She's never taken chloroquine or hydroxychloroquine in her life. No contributing medications whatsoever. But here's my point on this. Guess what her visual acuity was in both eyes? 20/20 in both eyes. And it's because of that point right there. The central 2 to 3 degrees were still hanging on in this particular case. Oh, by the way, her ERG was normal in this particular case. Sent her to the retina specialist. He thought she had some sort of weird Stargardt's disease. Not sure if I agree with that or not. But my point when this was, she was still 20/20 because that central island was hanging on at this point in time. OCT does a wonderful job of structure, whether it's around the nerve or around the macula, as you see in this photo right here. Multifocal ERG, again, I'm not going to talk about this tonight. I've mentioned it a couple of times, but basically a multifocal ERG says, how's this point doing? How's that point doing? How's that point functioning? How's this point functioning? How's that point functioning? Multiple focal spots, mainly used in Plaquenil toxicity. To detect Plaquenil hydroxychloroquine, it is one of the few tests that are recommended for detecting early Plaquenil toxicity. We're going to talk tonight about the flash ERG, the flicker ERG. Overall, how's the retina functioning? How's that retina doing from central to peripheral and everywhere in between? So it's an overall test of global retinal function. Again, it's a flash of light, as we've talked about already. So what are the indications? When should you consider a full field ERG, a flash flicker ERG? Let's just call it a flash ERG. Diabetes and diabetic retinopathy is number one. That is by far the biggest piece of the puzzle in our clinic, is doing this on patients that have diabetes and diabetic retinopathy. I would say this probably represents 70 to 80%. 10 years ago, 15 years ago, our electrodiagnostics clinic, as I said, was filled with cone dystrophy and retinitis pigmentosa and all these weird retinal dystrophies. And now it's filled with diabetic patients, patients with glaucoma, patients with macular degeneration, hydroxychloroquine toxicity, much more mainstream conditions. So diabetes, diabetic retinopathy is clearly the number one. But any condition that you want to say, how's the retina working? How's the retina functioning? How is the retina doing? I've got some mid-peripheral retinal hemes. I got some peripheral retinal hemes. I got some retinal changes that I'm just not quite sure of. You can get an ERG to see how is the retina functioning. They've got color vision issues, visual field defects, decreased vision, unexplained decreased vision. Have you ever got an OCT or a visual field to figure out what's going on? Why is this patient seeing 20/40? I'm seeing something in the back of the eye. I just don't quite know what it is. Let's get some structure OCT and function visual field. Problem with the visual field, it's subjective. It relies on the patient. Now we have an objective means. And that's the beauty with ERG, is this objectively. It does not rely on the patient. It objectively looks at function, which makes it very, very nice. If the patient can hold their eyes open and reasonably fixate, they're going to be able to have a flash ERG performed on them. So color vision issues, visual field defects, decreased vision. Doc, I can't see well at nighttime. You could explore, do they have a rod dystrophy or something going on there? Anytime you want to test retinal function, overall, the ERG is the test of choice. Let's look at the literature. There's more and more literature coming out in the role of electrophysiology in the early diagnosis and follow-up of diabetic retinopathy. Highlight at the bottom. Both the ERG and the VEP have proven to be successful tools for the early diagnosis of the disease and for ophthalmologic follow-up of diabetic patients. I highlight early. By the time that your patient has neovascularization growing off the disc, by the time they have a vitreous hemorrhage or a pre-retinal hemorrhage, your ERG is losing a little bit of its value. Even your OCT, they got a great big vitreous hemorrhage. What's your OCT going to tell you at that point in time? My point is early in the course of disease, before they have the hemorrhages, before they have the cotton wool spots, et cetera, et cetera. Most studies show unequivocally that the different types of ERGs detect local abnormalities, that's the multifocal ERG, or widespread pathology, that's the flash ERG, widespread, up, down, left, right, all those quadrants of the retina, even in very early stages of the disease. Electrodiagnostics 2.0, assessment of early retinal using new ERG protocols, more and more data coming out here. Screening for diabetic retinopathy using new dilation-free full-field flicker ERG recording devices. And the one I wanted to spend a few minutes on is this one. This is the Brigel study. And, what do we do in retina? We are, as Greg, I think it was Greg or maybe it was Joe said earlier, we own cornea very well. If somebody comes in with a corneal ulcer, we treat it. Somebody comes in with a preseptal cellulitis, we treat it. Somebody comes in with a red eye, we treat it with drops or orals or whatever it is. We also manage posterior segment very, very well. Oftentimes, what is our decision in macular degeneration? What is our decision in diabetic retinopathy? Am I going to watch this or am I going to refer this? What is the risk that this patient goes south in the next 1 year, 2 years, 3 years, 5+ years, whatever it is? If your diabetic patient tomorrow, was going to go proliferative in the next year, I bet you would change some things. If you knew they were going to be stable for the next 25 years, I bet you would change some things. So what is the risk? How likely is this patient going to stay stable? And how likely are they going to go south? So let's combine measures of retinal function and structure. Here's what they did in this study. They took fundus photos. They did OCTs. They looked at the back of the eye, structure. They did ERGs. An ERG, which I'm going to cover here in just a second, that's got diabetic retinopathy protocols, the DR assessment that gives you a diabetic retinopathy score. And they said, there's the function. Okay, let's combine this and see how likely these patients going to need intervention in the next 1 year, 2 years, and 3 years. What is intervention in diabetic retinopathy? Intervention in diabetic retinopathy, laser or injection or vitrectomy. That is intervention. How likely are these patients going to need intervention in the next 1, 2, 3 years? So if patients had structural abnormalities, again, they had hemorrhages, cotton wool spots, different stages of non-proliferative diabetic retinopathy, they had just structural abnormalities, that's how likely they need intervention in the next 1 year, 2 years, and 3 years. Okay? Let's add in function. They've got structural abnormalities plus functional abnormalities. Now, the ERG is abnormal. The diabetic retinopathy score, the DR score, is 23.5 or above. Remember that number, 23.5 or above. If structure and function were abnormal, that's what the percentage of patients needed intervention in the next 1, 2, 3 years. All right. How about if they still had structure abnormalities, but the ERG was normal? The DR score was less than 23.5. That's the cutoff between normal and abnormal. The ERG was saying there's not much ischemia here. That ischemia that Greg mentioned earlier, that's so important, the ERG so beautifully tells you how much ischemia is going on. ERG was normal, and that's what percentage of patients needed intervention in the next 1 year, 2 years, 3 years. Look how much data that gives you. Look how much knowledge that gives you. Who's going to go south? That patient that's got structure and function abnormalities, that middle group, you better follow them pretty closely. Maybe it's nutritional supplementation. Maybe it's an earlier referral. The bottom group that's got structure abnormalities, but the ERG was normal, a much better profile of who's going to need intervention, but they're much lower on that bottom profile. So structure and function, so very, very important. And this study identified that. You got to have both. One doesn't replace the other. You got to have both. So it's a great predictor of ischemia, as Greg said earlier. So let's look at the ERG testing. ERG testing here, again, electrode placement. It depends on the different, what device you have. There's really only one main one out there right now. I put this slide up just kind of for kicks and giggles. And I have used all of these electrodes, all 4 of them. Hard to believe we used to tuck gold foil down into the fornix there, down into the, the palpebral conjunctiva, DTL electrodes where we put a sticky on each canthus and a wire dangled across the cornea. Then we got eyelid electrodes. This top left photo is called a Berian Allen electrode. And it's awesome. Made by one family in Iowa. And they're like $1,500 for a pair of electrodes, and they're phenomenal electrodes. But you can see they got to put them right on the ocular surface. They hold the eyelids open. Little bit of pushback on that one. So the main electrodes that we use now are the eyelid electrodes, which work very, very well. So let's go through the printout, okay? And we're going to get to a question here in just a second. I get, many of you think ERG, and this is the same for me as well. And you go, oh, my ERG. There's lines going everywhere on this printout. I just want a nice picture. Give me a picture. Give me an OCT. Now you expect me to read these lines and this ERG? Come on, Nate. I can't do that. Well, let's make this simple, okay? None of us on this call, and I would guess Greg and Joe and certainly myself, none of us are cardiologists. None of us are EKG experts. Oh, by the way, I didn't mention this earlier. This is how I phrase this to patients, and they have loved it. I have been so surprised of how well patients they adopt the ERG, how they think this is so cool. Go, man, this is awesome. The latest and greatest technology that we now bring it right to them because it's handheld. And I tell them, this is the EKG for the back of the eye. Mrs. Jones, Mr. Jones, have you ever had an EKG before? And they're like, it's amazing. Every patient knows what an EKG is. They've either had one or they all know what an EKG. Yeah, I know what an EKG is. I just had one last week. Okay. I'm going to take this little device. I'm going to flash some lights in your eyes. Nothing's going to touch your eye. I'm going to flash some lights in your eyes. And this is the EKG for the back of the eye. Your EKG told your cardiologist, how's your heart functioning? How's your heart firing? Basically, how is your heart working? And hopefully it all came back functional and well. But if it didn't, that may be a sign that we need to change some things before major structural damage happens to your heart. This is the exact same thing. We're going to flash some lights in your eyes, and it's the electroretinogram, the ERG, and it's going to tell me how's your retina firing, how's your retina functioning, how's your retina working, how much ischemia is there, things like that. And hopefully it all comes back great. We've got a perfect ERG, but if it doesn't, that can be a warning sign for us, a red flag for us that we need to intervene before you have major structural issues like bleeding in the back of the eye, like swelling in the back of the eye, like your vision going down. They love that. Use that education and tell them that this is the EKG, the back of the eye, and it's going to tell us things that we didn't know before. How do you interpret this? Well, again, none of us are cardiologists, okay? But I bet all of us can recognize, oh, that looks like an EKG printout there. And again, we're not experts at reading this, but here's my point. You want these spikes, these peaks to be high, and you want it to have the right timing. You want it to be fairly quick, have the right rhythm. And all of us recognize that that looks like a normal EKG. Even though we are not cardiologists, that is normal. And all of us are smart enough to realize, well, that one's not abnormal. Or that one's not normal, correct? Flatlined. My point is this. Look for the strength and look for the timing, okay? And you go back to this down here. We're looking for the peaks to be nice and tall, and we want the timing to be quick. This little rectangular box down here is a guide for the practitioner saying, this is where this first peak should land. You want your ERG printouts, your ERG waveforms, which you can see here for the right eye, right here, and the left eye down here. You want your ERG waveforms to be like your athletes. You want them to be strong and quick, just like your athletes. And this one is nice and strong. It's within the normal ranges. It's nice and quick. And let me give you an example of abnormal, okay? Notice the difference between normal at the bottom and abnormal at the top. It's not as strong. The peaks have fallen. The peaks are not as high. It's not as quick. Remember, there's guidance here. These two rectangular boxes, that's where those two peaks should fall. These waveforms are weak. They're lower, so therefore they're weak, and they're late. They're slower. So this ERG, this retina is not firing as quickly, as strongly, and likely ischemia is the cause of that. So there's your interpretation of a regular ERG, a flash ERG. We can take it even one step better. We now have diabetic retinopathy protocols. This is the DR assessment protocol where it does everything that we just talked about. Okay, you can see here, there's the right eye, there's the left eye. It's looking at the strength and it's looking at the speed, but it also gives us a number. All of you like numbers, and I like numbers as well. We love our OCTs, but it gives us quantitative data, which makes it so nice, easier to interpret. And this now has a DR score that's been validated by Bascom-Palmer, and it's been studied in over 400 normative papers here. When you look at this, and this DR score is like Greg's golf game. It's the lower the number, the better. You know, Greg is a scratch golfer, just an incredible golfer. The lower the number, the better. And the number you want to remember is 23.5. 23.5 and lower is normal, and 23.5 and above is abnormal. The lower the number, the better. Just like Greg's golf game shooting 65. You have a number like this is very, very normal. 15.1 looks great, within normal limits. Our peaks here are right where they should be. And again, you look at this data here, and it's all in the green, looks great. Let me dive into the weeds one last time on this, okay? This is the time, does two different brightnesses in this approximately 1 minute test in each eye. Okay, 1 minute test in each eye. It has the speed, which we already talked about, and it has the strength. Think of the speed as a 100-yard dash. If you did a 100-yard dash, do you want a big number or a small number? And the answer is a small number in a 100-yard dash. And the same thing is true for these percentages here for the milliseconds, the time. The lower the percentage, the better. The lower the percentage, the better for the milliseconds, okay? The strength is a weightlifting competition. If you were entered into a weightlifting competition, do you want a big number or a small number? And obviously you want a big number. So unlike the time where I want small percentages, those are better, more normal. For the strength of the ERG response in microvolts, I want this a higher percentage, the better. That means a stronger retina response, right eye and then left eye. So that's how you interpret this. I look at the overall number, where are we at, look at the colors, and then I dive into these percentages. You know, if you look at this, which one of these, the right eye or the left eye, has a stronger ERG response in terms of the strength? And it's very clear from both the waveforms as well as the percentages that the right eye is a little bit stronger than the left eye, both within normal ranges. But if you were nitpicking and learning on this, the right eye is a little bit better than the left eye. Compare and contrast to that one. How's this looking? Immediately go to the DR score, 24.6. What does that mean? This patient is more likely to progress in the next 3 years when they have an elevated DR score. That's what that means. There is that silent ischemia going on that Greg referenced a little bit earlier. This is telling you that your patient needs to be followed more closely and they are more likely to progress. Look at those waveforms, way reduced. The strength is down to very, very low. Speed is not terrible, but this is a reduced ERG, and this is saying red flag, red flag, red flag, doctor. So I'm going to pause here. And we have reached question number 1. Joe?
Do you have it, Greg? You want me to get it? All right.
Oh, I was muted. It's open. It's been open.
Okay.
So I have it double muted. So all of the following tests examine structure in some way during an eye exam. Which one looks at function? OCT, fundus photos, DFE, and ERG. And let me see how it is rolling in. All right, looks like we have a good response. Nate, you're doing a good job here. We're gonna display the answer. And 97% are saying ERG there, Doc.
There we go. Any other questions at this point?
No, you're all caught up.
Okay, here we go. And actually, I have a second question right after that. I put them back to back. Which of the following is a normal DR score for a patient taking the DR assessment with the handheld ERG? Which one of these is the most normal DR score?
17.5, 23.5, 26.5, or 32.5. They're rolling in here, Nate. I see the answers rolling in, the responses. I haven't displayed it yet.
And Joe, my apology. I'm not familiar with your golf game like Greg, so you may beat him on a regular basis.
I do not. I am not a golfer. It has not worked its magic on me yet.
So Nate, as you're talking there too, we're talking about how that ERG and kind of how that wiring in that inner retina is. And we kind of focus on ischemia, but it's also a lot of other things happening within that kind of neurological workup. Ischemia makes it easier. Just want the audience to realize it just kind of makes it a little easier when you do the talk. But if you think about when you look at an OCT, you have the photoreceptors, which is the kind of the most, inner part. And then you have, the outer part of the retina. And then close to where the vitreous is, that's where all those Mueller cells and bipolar cells. And that's where this kind of wiring is kind of breaking down that's out there. So that's where the kind of think of this malfunction occurring. And that's one of the main culprits is ischemia and then all the other cellular breakdown that's occurring.
All right. We
good. All right. So we have 17.5 as our biggest answer at 56, and we have 23.5 at 29%.
Yep. And I kind of said 23.5 is the cutoff. So the most normal here would be 17.5. Remember, the lower the number, the better. 23.5 would really be at that cutoff of normal, abnormal, and the higher 26.5 and 32.5, definitely abnormal and indicate your patient is likely going to progress through the stages of diabetic retinopathy. So we will come back to ERG in just a few minutes. So let's talk on color vision. This is something that we have looked at over the last 4 or 5 years, and you don't often think of color vision when it comes to diabetes and diabetic retinopathy. We all think of color vision when it comes to hereditary conditions. Your deuteranopes, your protanopes, they've got hereditary. I think it's last I heard is about 1 in 12 patients, roughly, 8% or so of males are going to have some sort of color vision anomaly, but that's often hereditary. But there is more and more being realized about acquired color vision deficiency, whether it's in wet AMD, whether it's in glaucoma, or in this case, diabetes and diabetic retinopathy. I did a webinar last week on that through our College of Optometry. It's been shown since as early as the late 70s and early 80s that patients that have glaucoma have color vision abnormalities. Patients that have AMD have color vision abnormalities. So why haven't we been doing color vision in these patients? Is because we didn't have a great test that would be able to look at this, quantify it. It's been validated against the anomaliscope, which is the gold standard that none of us have in practice. It's only in the research center. So to be able to have something that's clinically usable and breaks down the red cones and the green cones and the blue cones, your long wavelength, your medium wavelength, and your short wavelength cones, because different cones can be affected in different diseases, as we'll talk about here in just a little bit. So this is a test called the Rabin cone contrast test. And this is on a little tablet, or it can be on an all-in-one desktop as well. And this is cone isolation technology combined with contrast sensitivity. So both are in one. And we test this one eye at a time. So we're covering the left eye, we test the right eye, then we cover the right eye and test the left eye. And you'll see in the screen here, as it will test the red cones, and then the green cones, and then the blue cones, and it's got contrast sensitivity as these letters fade out over time, and it gives you a score. This is a threshold test, and it's going to give you a number somewhere between 0 and 100. And we'll go through that in just a little bit. I want to show this video one more time. So again, you can see that, it's easy to see that red D, and then it fades with that contrast sensitivity. Again, isolating the cones, that cone isolation technology and the contrast sensitivity to give us a score. And we now have the literature that guides us that we can follow these different cones, red, green, and blue, over time to detect changes from macular degeneration, glaucoma, and diabetic retinopathy as well. So again, it's a functional complement to the OCT, just like our ERG is. You're still going to do your OCT. You're still going to do your fundus photos. You're still going to do your DFE. But more and more studies out there showing a good percentage of our diabetic patients have abnormal color vision. Abnormal color vision. And you can see even when they have no retinopathy. There's a study by Wolf investigating type 2 diabetes, diabetic retinopathy, multifocal ERG, and somewhere between about 40 and 50% of patients, whether they had retinopathy or not, had abnormal color vision. Okay, study by Carson looking at showed an even higher percentage, whether they were pre-diabetic or diabetic, showing abnormal color vision. Again, function can fall before we see signs of damage on that structure.
Nate, before you go too far, go back 3 slides to one where they had the OCT. One more. I think that's, I've seen this. I've seen you give this lecture. I saw you give it in Nashville this year at the Academy or at the AOA. You did a great job. And I love this. And I think this is one of the best slides that's there because you're showing here the cones in that top graph, but that bottom is a 6 millimeter cut of an OCT, B-scan OCT. And it was my aha moment to realize I used to think that the cones were packed, that color cones were packed within the foveal pit.
Yep.
That whole 6 millimeter slice right there is what this Rabin cone contrast test is testing. Those reds, those greens, and those blues are that whole OCT scan there. So you're testing that whole area right here. I think this is one of the biggest aha moment. I have this device in my practice. And when I saw you do this, it wasn't this year. I saw you do it this year. You did a great job. It was a year ago when I saw this and you had that up here. And I actually got to digest this slide. I think that's amazing that when people are looking at an OCT, that 6 millimeter cut down there, we have all those red arrows and all that blue wording. That's the whole area we're testing where all those cones are located.
Yeah. The density is pretty high in the fovea because that's a small area. And I can't remember the number off the top of my head, Greg, but the percentage of your total cones that are actually in the center of the fovea is actually a very, very low percentage. Yeah, it peaks in terms of density there, but there's a good amount of them located, as you just said, outside of that fovea area. And that's what this is testing.
Yeah. Thank you. Thanks for going back.
You bet. Again, looking at this test, again, the reds, we're going to go through a printout here in just a second and kind of my guide for how I read this on the next slide, but just showing another poster here and looking at how does this correlate in diabetes and diabetic retinopathy. Again, this is a useful method for evaluating acquired color vision loss in patients with diabetes and diabetic retinopathy. Again, I've got the slides. You guys can take a look at that. So here's how I interpret this. I have a slide for glaucoma. I have a slide for macular degeneration. This is my slide for diabetes and diabetic retinopathy. Overall, look at number 4. I'm going to look at all of them. Okay, it could be any of them that are reduced. Any of them could be blue, could be red, could be green. But in general, this is a very big generalization. I look at the blues first, and then the reds, and then the greens. And again, it can be in any order. Doesn't have to be late stage disease, but generally speaking, in diabetes, if you made me say, Nate, which one is the most important to look at? I would answer the blues. The blues in diabetes and diabetic retinopathy tends to be affected first. Again, there are many, many exceptions to that. And I'm going to show you some cases that are exceptions in just a few minutes there. But blues, then red, then greens, but it could be any of them. Here's what your printout. This is how you interpret this. And it's very, very simple. It's very, very easy. You can see the right eye. You can see the left eye. We're looking at this printout. It gives you a score from 0 to 100 for each of the 3 cones, and 90 to 100 is normal. So 90 to 100 is normal, 75 to 85 is borderline, and 75 to 85 is borderline, and less than 75 is abnormal. The lower the number, the worse it is. This is the opposite of the ERG, where we talked about the DR score. The lower the number, the better. Here it is, the lower the number, the worse it is. You want to be at 100 or 95 or 90, but you can see it breaks it down really easily. So you can follow this patient over time and, okay, whoop, the blues are decreasing, the greens are decreasing, the reds are whatever it's from. But just like your visual field, just like your OCT, you guys do progression analysis over time. This software now has progression analysis, and you can follow this color vision over time. And hopefully, your patient, this is another one, pretty normal. Okay, normal in the right eye. Look at the left eye, maybe the red one's reduced just a little bit. Of note, I'm not talking on macular degeneration tonight, but the literature is fairly clear now that in macular degeneration, the red cone is most important, the longer wavelength cone. Macular degeneration is an outer retinal condition.
20 days and 20 minutes summer dinners.
It's an outer retinal condition. So red cones in AMD, I look at all of them in glaucoma, maybe lean the green cones, and in diabetes and diabetic retinopathy, it is the blue cones. Generally speaking, if you made me give you the most common pattern that we see in diabetes and diabetic retinopathy, it is what's called a down and to the right. DR, diabetic retinopathy, it goes very nicely with down and to the right. DR, down and to the right. The blue cones affected the most. And you can see this slant here of down and to the right. Again, that is an extreme generalization. This can affect any of those, as I've said before, but remember diabetic retinopathy down and to the right on the Rabin cone contrast test. Okay, so again, here's another one. This is a different example of a patient that, obviously much more reduced in the right eye compared to the left eye, and the greens were hit the most in their right eye. And again, we'll go through some cases in just a second. So what are you going to do differently? When they have an abnormal color vision score, again, less than 85. Less than 85 is abnormal, or a decline of 15 or more. So that's the other question I get quite often is, okay, you're watching this over time. What is significant? If they go from 95 to 90, that's not significant. That's only a change of 5. Okay. 15 or more. These go in 5-point increments. So it's 100, 95, 90, 85, 80, 80, 75, 70, all the way down. 15 points or more. That is the change that I'm looking for that I consider clinically significant of these over time. Just like visual fields, just like OCTs, just like IOPs, you can always repeat the test to get more data and see how we're doing on that. You can always repeat it and validate what you've seen in that falling. So 15 or more, that's what I look for progression. So less than 85, abnormal, a decline of greater than 15. Again, are we preventing onset, preventing progression? We'll talk more about this in just a little bit. So I'm going to pause here for another question. Which of the following is a normal Rabin cone contrast test score for the red cones? 95, 75, 55, or 35?
The question is open.
This is really for the reds or the greens or the blues, because they're all scored the exact same. From 0 to 100, which one of these is a normal score?
So Nate, I want to throw this out to you to see if we're on the same page here, is that when we're doing the color vision testing, we just showed that OCT, and I kind of look at an OCT as being kind of inner and outer.
Yep.
Down where the RPE is, that's where the photoreceptors are. Above in the inner, that's where we know where the capillaries are of the retina. But that's also kind of that neurological wiring that's going on between the bipolar cells, Mueller cells, all that kind of wiring. When I see that down into the right, I don't consider that to be kind of a photoreceptor issue down at the RPE. I kind of think of that as an inner retina issue where the neurological wiring is going bad, and we just happen to be picking that up on the color vision test here.
I completely agree. I completely agree on that. And I don't know if it goes back to, Greg, the long wavelength, the medium wavelength, the short wavelength, and how light go longer wavelengths penetrate deeper, shorter wavelengths stop short? I don't know that we fully know that answer, but I completely agree. And I think AMD is more of a red cone. And as you get into more neurologic disease, inner retina, as you said here, I think this is the protocol, or this is what you're going to see in terms of that. So absolutely, I don't think outer retina in a printout like this. I think of inner retina conditions like diabetes. Yep, I completely agree.
Yeah, so I want the audience to think about like what's happening here with this. Nate's doing a great job of discussing function versus structures. That's why if you do that B scan, it's going to look normal. It's the neurological processing that we're picking up the defect here. So I have it displayed here, and you got 73% saying 95. So we got a good job here. 73% saying 95. The next one is at 13% being 75.
All right. Here we go. Continuing to move on. Let's just spend just a few minutes on diabetes and, on OCT angiography. And before we get to some cases, OCT angiography, hard to believe we've had this in our clinic for 8 or 9 years now. OCT, I think it was 2016 we got this. And, it started as a qualitative picture, a beautiful picture where you looked at the capillaries and you saw this capillary disease, as we talked about earlier, and capillary dropout, which we couldn't see with our naked eye with fundus photos and our DFE. We had to do a fluorescein to see that capillary dropout or that enlargement of the foveal avascular zone. And now we could acquire this so much quicker, just like an OCT, and you got this great picture. This awesome picture that looked like this, and even this is even after we had these numbers in the bottom left here. But at the start, it was just the en-face imaging, the different slices through the inner plexiform, the internal limiting, then the outer layer, and then the RPE, and then the choriocapillaris, the superficial capillary plexus, the deep capillary plexus, But we just had slice, 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 and it was great pictures. And we looked for enlargement of the capillary, the foveal avascular zone. We looked for capillary dropout, but we didn't have any numbers early on. And then we started to get numbers that looked like this, and you go, oh, now I got ways to analyze this. And is there progression? Because I can follow this over time. And then we got measurements of the foveal avascular zone where the software gave you that number. And you go, okay, we now know from the literature and from clinical experience that enlargement of the foveal avascular zone is an early sign of diabetic retinopathy and progression of diabetic retinopathy through the stages before they are showing hemorrhages, microaneurysms, cotton wool spots, venous beading, etc. We can see enlargement of this foveal avascular zone. We can get printouts, and it can break it down into different sections and quadrants of what is the vessel density in different areas of the macula and different areas of the retina. And it makes it just beautiful. And again, here's another one. Following that foveal avascular zone, we know it correlates with the disease severity in diabetic retinopathy. We should have a fairly small, fairly regular foveal avascular zone. And as that gets bigger, as that gets more irregular, that is a sign of the DR getting worse. And we need to intervene with that. Capillary dropout. Again, here's another foveal avascular zone showing more capillary dropout. Look at those blue spots, as I call them. As you see those blue spots, that is capillary dropout. And this is a capillary disease, as Greg said earlier there. And progression analysis over time. So I wanted to make sure I hit that. And we're going to come back to that in cases in just a little bit. So for just 5 or 10 minutes, we talked on ERG. We talked on color vision. We talked on OCT angiography. That's all great. All right, we've got this new testing that pairs with our OCT and our fundus photos. What do we do about it? Well, I'd like to think that if your doctor did an EKG on you and your EKG came back abnormal, that they wouldn't go, no, whatever. Yeah, you're fine. We'll see you back in a year. No worries. We'll just wait for you to have a heart attack and die. You're good. No, they would intervene. They would change something. And my point is if your patient has an abnormal ERG, has abnormal color vision on the Rabin cone contrast test, has capillary dropout on the OCT, we shouldn't just say, oh, whatever. We'll see you back in a year. We need to change some things. Maybe we consider a nutritional supplement. Maybe we change the follow-up schedule. Instead of seeing them in 12 months, 6 months. Maybe it's 6 months, it's 4 months, whatever it is. Other testing. You got an abnormal ERG, let's get some OCT-A and see the degree of foveal enlarging, the degree of capillary dropout. Maybe it's a fluorescein. Better or more patient education, more communication with their PCP, earlier referral or save referral. We are going to change a lot of things. We need to be gone with the days of control your blood pressure, control your blood sugar. I'll see you back in a year, Mrs. Jones. We have lots of things that we can change. Why should we care? Because prevention beats treatment every single time. Every single time, prevention beats treatment. And if we can save intervention, needles, laser, vitrectomy, we are winning for our patients. So I want to highlight this study, right? And there's all kinds of supplements here. You can see the DVS here, the Science-Based Health makes, we get lots of different companies. I want to highlight this study. This is the DIVFUS study. And this was released about 9 years ago. And this was by Paul Chouse, the late Stu Richer, and Jeff Gerson, three of the leading minds in retina, in my opinion, in optometry. These were three optometrists. Paul Chouse, in my opinion, is the genius of all geniuses when it comes to diabetes and diabetic retinopathy. It hits home for him. I was attending a lecture at the Academy meeting about 9-10 years ago, and I remember listening to this guy named Paul Chouse, and he showed a picture of one of the most lasered retinas I had ever seen before. I mean, there was PRP everywhere, and it's his retina. He was diagnosed with type 1 diabetes in his first decade of life, and he's had it for 50 plus years. He is so knowledgeable about diabetes and diabetic retinopathy. Lead author on this. Stu was a pioneer in nutrition. Jeff Gerson is just incredible in retina as well. So here's what they did. They took this supplement, okay, and they took a bunch of patients that had no retinopathy, mild retinopathy, or moderate retinopathy. Sound familiar in your practice? No retinopathy, mild retinopathy, or moderate retinopathy. The first half of the disease, and half of them, they put them on this supplement, and the other half, they gave them a placebo. Looked like something, but there was nothing there. There was nothing in there. So this is a placebo-controlled trial, 6 months. Let's go 6 months and see if this supplement is better than the placebo in a whole bunch of things. Now, what's the strategy when you choose the ingredients? This is Paul Chouse's slide. Full credit to Paul Chouse on this. You've got to choose ingredients, choose them wisely. Multiple mechanisms of action. You take a look at all these ingredients and what they do. I'm going to pause here and just let you digest this slide and all these different ingredients and what they do and how they help retina, how they help vasculature, how they help retinal vasculature. Again, I think the days are gone of watching and waiting and watching and waiting, and let's be more proactive. We all know that lutein and zeaxanthin are important for the macula, important for the retina, and a lot of other healthy stuff here as well. If this is something that interests you, send me an email. I will send you a copy of this study and a document by Paul Chouse. It's 12 pages long. It's got 100 references from the literature, but this 12-page long document contains a paragraph or two on every one of these vitamins, minerals, everything that's in this proprietary blend: benfotiamine, N-acetylcysteine, grapeseed extract, resveratrol, green tea leaf, pycnogenol, all of this stuff of why this is healthy for retina or vasculature. It is an in the weeds document. But send me an email and I will send you this study, as well as the document that says why all of this is so very healthy. And it's basically tied to this slide right here, what each of these does. If we can do this, that is good things. That is good things. Okay, so let me quick
So Nate, go back to that slide there. So you're targeting mitochondria there, which is fantastic, right? And the mitochondria, you can actually see that's what the ellipsoid zone is on a OCT. You're helping out with inflammation. You're reducing oxidative stress. What I want to point out is I applaud, because I think in the last few years I've been taking a lot of functional medicine, is that I think as we keep expanding, it's just going to continue to be more comprehensive in what you're saying there. You want to cover the mitochondria, you want to help with inflammation, you want to reduce oxidative stress, and you want to normalize that hormones. The other thing is that I wanted to point out while you have this up, we did have Paul Chouse here a few weeks ago doing his diabetes lecture, and he pointed out that it's, time in range. Hemoglobin A1C, we still all talk about because that's kind of the easiest and that we feel comfortable with. But with all these continuous glucose monitors, it's the time in range or time under the curve, which is now more important. And hypoglycemia is terrible for diabetic retinopathy. Hyper is bad too, but it's that hypo too that happens. So it's that time in range. So just kind of correlating, kind of wrapping everything you're doing here with this function, nutrition, your flash and your color vision, just tying it all together there. Awesome. I love it.
Great pearls. Great pearls. So what they find here, pre and post analysis, they looked at a lot of stuff. Did they look at visual acuity? Surely they did. But what's the visual acuity of patients with no retinopathy, mild retinopathy, and moderate retinopathy? We already talked about it. It's 20/20 or very close to that. They looked at contrast sensitivity. They looked at macular pigment scores. They looked at color vision, the Rabin cone contrast test, macular perimetry, OCT, lipid levels, systemic markers, inflammation, diabetic peripheral neuropathy scores. And what they found was this. Lots of numbers here, busy slide. After 6 months, everything that with an arrow next to it was statistically significant, statistically superior in the supplement group versus the placebo group. Color vision was better. The central points in a visual field, they were more sensitive at detecting that. Macular pigment scores were better. Lipid levels were better. Inflammatory markers were better. Diabetic peripheral neuropathy scores were better as well. After 6 months, imagine 12 months, imagine 18 months, imagine 24 months. At that point, we've got to get that mitochondria better, as Greg said, and those other markers as well. And you can't do that overnight. You can't do that in a week. You can't do that in a month. This is long-standing chronic disease, and it's going to take long-term effort and chronic management moving forward. So patient benefits, again, you can see it there, all statistically significant. Contrast, color, visual field sensitivity, reducing the C-reactive protein, no effect on A1C. Again, all statistically significant. In 2024, who do I recommend the DVS formula? Any degree of diabetic retinopathy. They have structural issues or an abnormal ERG or an abnormal Rabin cone contrast or an abnormal OCT, and especially if they got both. Because if they've got abnormal structure and they got abnormal function, they are heading down a road that you and I don't want them to go down. So structure, you remember the Brigel study that we talked about. They're poorly controlled, reduced visual function, low macular pigment, or poorly controlled. Again, that time in range, as Greg said, hemoglobin A1C, blood sugar, whatever it is, any one of these, we're making a recommendation. The longer they've had diabetes, maybe we make a recommendation. Now, that's the weakest of the four, because we have all had patients that have had diabetes for 20 years and are doing great. A1C is 6.2, and their vision is 20/20 sharp. And you may not need to make a recommendation. But what does the ERG say? What does the Rabin cone contrast say? The OCT may show that the structure looks good, then the fundus photo looks good. But what does the function say? It will pick up changes before the structural changes in many, many patients. So, all right, beneficial effects of diabetes and diabetic retinopathy. Again, we talked about how this changes things as well. Let's pause here for question number 4 before we get to our cases. Which of the following diabetic patients does not likely need a recommendation to take nutritional supplementation? Well-controlled 3-year diabetic with an A1C of 6.2, 35-year diabetic with moderate NPDR, 15-year diabetic with macular edema, or a 10-year diabetic with reduced vision and subjective visual complaints. Which one is least likely where you would recommend a nutritional supplement?
The answers are rolling in, just so you know.
Greg, Joe, we're well-versed in nutritional supplementation and AMD. Would you agree, historically, we are less well-versed in diabetes and diabetic retinopathy and how supplements can benefit our patients?
Yeah, I think you're entirely right about that, and I like there's good science behind it. We have to be able to explain to the patients it's not our opinion, but we have good science behind it. AREDS, good science behind it.
Yep.
Yeah, it's a tough part to talking because we all grew up in an allopathic way, allopathic opposites curing, right? So you have a sty, you give them an antibiotic. They have a high sugar, you give them metformin or insulin. This is why I've kind of in the last 6 years taken a lot of functional medicine and speak to this from the stage, because functional medicine, chronic disease is not our strong point, but go way back to the beginning when you said, do you think we're going to be doing more of this? I think this is optometry's opportunity to talk about exercise in that sympathetic system. Talk about that parasympathetic, that sleep, that meditation, those breathing exercises, parasympathetic, sympathetic, nutrition is what we just covered there. And then I think the next one is wait till we talk about the gut microbiome. I mean, I think that's the next holy grail too, for us that's out there. So that's integrative medicine, as opposed to functional or allopathic.
Yep.
All right. So you got 93% saying well-controlled 3-year diabetic with an A1C of 6.2.
All right. Let's finally get to some cases here. I'm going to go quickly through this one. I've got 5 cases I want to get through. I shifted them around here. This is a 50-year-old female. Interesting case, Joe. Interesting case, Greg. For punctal plugs. I don't even usually see those patients. The resident or the student drop in the punctal plugs in our dry eye clinic and send them on their way, and I'm not even usually in the room for that because they can handle punctal plugs. But this observant 4th-year student noticed, I checked visual acuity. Visual was down a little bit in that left eye, 20/40 in a diabetic, hypertensive, last A1C 8.9, blood pressure reading, as you can see there. So we're hypertensive. We have diabetes, and, maybe a little bit uncontrolled there, as you can see, but vision is down in the left eye. OCT in the left eye. All right. Clearly showing some changes in this left eye in the OCT. I think most of us on this call know that's classic central serous chorioretinopathy in this left eye. Vision 20/40 makes about sense. Depends on the case there. There's our posterior pole photos. We took pictures of the left eye. You can see the bubble there. And I see that bubble or that fluid with this central serous chorioretinopathy. And I already gave the answer. It's central serous chorioretinopathy in that left eye. Well, we took a picture of the left eye. Well, might as well take a picture of the right eye as well. So there's a picture of the right eye. Again, this is not the eye that we were concerned about. Not the eye we were concerned about at all. This is the 20/20 eye. It's the left eye that has reduced vision, central serous. But we took a picture of the left eye. Let's take a picture in the right eye. Typical follow-up for central serous. I was trained by a retina specialist, among others. You're typically going to observe these patients. Most often, there's some treatments out there available, but by and large, we usually give it time. And I remember our retina specialist saying, see him back in a month for an OCT and a vision check. For central serous, we'll watch it, make sure this improves over the course of the next 1 to 3 months. So that's what we did in this particular case. This is not this patient's OCT, but just a representation that the OCT in the right eye looked great in that 20/20 eye. We'll see you back in a month. 1 month later, and this patient, the central serous in September, central serous in October. So you can see it is getting better in that left eye there, less fluid on the OCT. There's a nice picture of the back of the left eye, vision hovering around 20/30 minus in this left eye. Looks good. Central serous moving in the right direction, not fixed yet, but moving in the right direction. And we took a picture of the left eye. Let's take a picture of the right eye as well. There's the right eye. Give you a couple of seconds to digest that. And, was that, did it look like this a month ago? There, there's the macula from where we took a picture a month ago. There was the macula. Boy, I didn't see those hemorrhages a month ago in that right eye. And man, the nasal side of that nerve. Look at that, the findings that you see in the nasal side of the nerve there. All right. Well, shame on me. I said, central serous is getting better. I largely ignored the right eye at this point. Shame on me. Slap me on the wrist for that. And we see you back in, a month later, now in November. So we've seen the patient in September, October, and now November. There's the September OCT and the October OCT and the November OCT. Central serous is doing what central serous often does. It's resolving on its own, at least going in the right direction in this particular case. And you take a look at the back of the left eye, looks good. At least it's resolving in that central serous. All right, let's take a picture of the back of the right eye. Back of the right eye here. And got different pictures. I'll cycle through. Better or worse than a month ago? There's the red free.
We had quite a bit of vasculopathy going on there, and it certainly does look worse.
Yep. This is not this patient's OCT, but just a representation of what the OCT looked like. No findings at all, no edema in this eye. So here's my question for you. And again, we're not going to poll the audience here, but just think to this to yourself. You don't have to answer it. We know we have central serous going on in the left eye. What's going on in the right eye here? Again, you don't have to answer this one. Just think of this to yourself here of going, all right, we've had some changes going on. Vasculopathy, as Joe said, in that in the right eye. Artery occlusion, vein occlusion, ocular ischemic syndrome, diabetic retinopathy, something else. I don't know. Get this out of my office. Joe, any comments, when you look at what's on your differential of what this could be in this 53-year-old female that has diabetes with an A1C close to 9, with, blood pressure of 152 over 96 or whatever it was. What's on your differential? What could this be, Joe, when you see photos that look like this?
When I see photos look like this and I see dilated venous tortuosity, my first thought begins to go to a thrombus is developed at the level of lamina cribrosa, and venous drainage is actually relatively depressed or poor in this case. Looks like it's hard for me to see what's happening nasally on the disc. Could be telangiectatic vessels. I don't know if we have neovascularization. Doesn't look like collateral vascularization, but it does look a bit edematous to me.
Yep. And, when I ask this question, what do you think's going on here? Usually the number one answer is ocular ischemic syndrome. Number two answer is a retinal vein occlusion. I agree with Joe. My number one differential in this case was a vein occlusion because of those dilated tortuous veins there. So that was my number one. We did send this patient for carotid testing just to rule out ocular ischemic syndrome. I will tell you that those carotid scans came back completely unremarkable. There was no blockage there. We've ruled out ocular ischemic syndrome. Doesn't fit for an artery occlusion. Diabetic retinopathy. I just think the asymmetry in disease between one eye and the other really speaks against the diabetic retinopathy. Not that it couldn't be that, but I don't think so. Dilated tortuous veins, really leading to a diagnosis of retinal vein occlusion. If this was we just diagnosed, again, we're not going to open this up. There's no polling here. Just have you think of this. You just diagnosed a mild vein occlusion. I had an attending doctor call this venous stasis retinopathy. Good friend of mine, Leo Scorin. I did 4 months rotation with him. I remember seeing a patient. It wasn't this one, but the retina looked just like this. And he called this venous stasis retinopathy. I think there's different ways that you can look at that. But you just diagnosed mild venous disease, a thrombus at the level of the lamina cribrosa, and we've got venous engorgement, got trouble draining the blood from the eye, those veins. What would you do at this point? And I think you could educate, Joe, I'll kick it to you. How would you handle this case, Joe? We'll see if I did it differently, if I did it the same.
Now, a couple of things. I want to give another clinical probe of ocular ischemic syndrome. One thing I would want to know, if I'm considering it, is what is the intraocular pressure? And the vast majority of patients who have ocular ischemic syndrome are hypotenuse. There's usually a significant difference in the pressure. You might be looking like a 6 or an 8. So if they have normal intraocular pressure, I don't worry as much about that. Leo's term venous stasis retinopathy, that really kind of goes to the ocular ischemic syndrome. I think now we can probably call it hypoperfusion retinopathy, where there's not enough blood flow, blood pressure getting it in, getting it through the vascular system. That's why it pools and it starts to leak. But this is, in my opinion, based upon the vasculature, an early or impending or developing central vein occlusion. And there's not really much we can do to divert anything at this point. There's nothing treatable. You showed the OCT. OCT was not, it had no edema. It's not injectable. We really, if it wants to get worse, it's going to get worse. So we're going to watch it carefully. I wouldn't do anything else. I certainly wouldn't send a neuro or retina. I would just watch the patient.
And that's exactly what I did as well. And again, I think it's important to look at, could you, obviously we're going to consult with the PCP with, the vascular stuff, but educate and observe is how I handle this. I suppose you could send it to retina if you wanted to CYA, which is certainly something we all consider. But if you send this to retina, they're going to watch for the development of two things. They're going to watch for the development of macular edema, which you can do with your OCT, and they're going to watch for the development of neovascularization, ischemia, etc., which you can do with your ERG. And I already showed this slide in the past, how to interpret this. This was this patient's ERG, and it was a very, very normal ERG, which lets us know, is this an ischemic vein occlusion? Is it a non-ischemic vein occlusion? It's mild at this point. Vision is very close to 20/20. I want to make sure that this stays as a non-ischemic vein occlusion, and the ERG really gives me confidence in this case that, hey, OCT is telling me no macular edema, and the ERG is telling me this very likely is going to stay non-ischemic. Another layer of evidence, another level of evidence that you can watch this and hold on to it in your practice. ERG gives you that. You've got structure, and now you've got function with the ERG there. So again, normal ERG, I watch this. I'll see you back in a month is what I told the patient. Guess what? He no-showed over the holidays in December 2023. Just to make me nervous, I think. 2 months later in January of 2024, I'm like, golly, is he going to come back with the blood and thunder? It's been every single visit getting worse, worse, worse in the right eye. And luckily enough, the ERG was right. The ERG was right. You take a look at this, and that hemorrhaging got a little bit better. The patient's vision never left 20/20, never left 20/20 in this particular case. So this was a mild, impending, never went bad vein occlusion, and the ERG was very, very helpful. The ironic thing in this case on this visit, the vision in the left eye was down again, and that was the left eye's OCT, and we have recurrent central serous chorioretinopathy there. So, all right, in my last
Hey, Nate, let me make a comment on if you're sending that to the primary care doc, which I probably would have done, but I probably would not have sent a letter, or I would have sent a letter, but it would have been a follow-up call because with a photo to show the asymmetry, because they're going to go right down hypertension, they're going to go right down diabetes, it's diabetic retinopathy. You're going to show you want to explain the asymmetry. You're kind of looking for the unicorn here. And I would just explain to the primary care doc, look, I'm looking for anything that's going to clot or some type of blood dyscrasia, and I'm not looking for the obvious high blood pressure and diabetes. At least a little courteous call for the patient, but also for the primary care doc.
Yep.
And also, Nate, one thing I noticed on that photo is now I can clearly see those are collateral vessels telling us there's been a venous outflow obstruction.
Yep.
So guys, when you see something like that, you may not have seen the evolution that Nate did, but when you see those footprints, you know what's happened to the patient.
Yep. Absolutely. Those were collateral. At least that's what I call them, collateral vessels. The body formed those. So, all right, my last 9 minutes, I'm going to try to go through 3 more cases very quickly just to show the benefits of structure and function. 63-year-old female, longstanding diabetic, hypertensive, hyperlipidemia. You can see her medication list there. Sent in because vision wasn't very good. 20/50 in both eyes. Unhappy with her vision. Again, 30-year diabetic, hypertensive, and her last A1C 11.0. Certainly not where we'd like it. So maybe that's why vision is down. There's the back of the right eye. And so I'm going to bleach out the nerve here, unlike the last patient that had some kind of collaterals and stuff going on the nerve. This one nerve looks pretty good there. Bleach it out to get a better view. This is a artifact here, artifact there. Back of the left eye, again, artifact here and artifact there. Overall, for a 20 to 30-year diabetic, actually nearly 30-year diabetic with an A1C of 11, this actually looks not too bad. And the OCT confirms that as well. If I just showed you this OCT and nothing else, you would go, well, that looks pretty good, actually. That might be close to 20/20 OCT there in both eyes. So it's like it left us scratching our head of why is this patient 20/50? We looked at the ocular surface. We looked at the lens. We knew it wasn't from that because they ruled that out in the referring exam. Is this neuro-related? We actually did a visual field in this patient just to make sure it wasn't neuro-related. There was no neurological defects. But again, I think this highlights the importance of structure and function. Structure looks good. Structure looks good. Overall structure looks pretty good on this fundus photo in the back of the left eye, and the right eye was pretty decent as well. But when you look at function, and remember, we talked about the ERG. Look at that ERG, the DR score. It's handheld now. You walk it right to the patient. 23.5 and above. 23.5 and above is abnormal. This is a reduced ERG in both eyes, and this shows that this patient that has structural issues also has functional issues. They are much more likely to progress over the course of the next 3 years, and we need to watch this patient very, very closely. I explain it this way. Mrs. Jones, you're on a road right now that you and I don't want you on, and that road is progressing quickly to vision loss. And we need to throw this in neutral. We need to throw this in reverse in any way that we can, because you're 63 and I want you seeing at 73. I want you seeing at 83. If we can get there. But this ERG, your EKG for the back of the eyes, your ERG is showing your retina is not functioning like we should. Oh, by the way, there's her color vision. I showed you this earlier. Her color vision is reduced, especially in that right eye as well. Okay, again, we're looking for the down and to the right. Everyone's a little bit different. This one didn't show exactly like that, but still, we have an abnormal color vision, right eye worse than the left eye, okay? Remember the role of electrophysiology. Remember nutritional supplementation. And what's been cool to see, and this does not happen in all patients, is, and I give her credit, she gets all of the credit. To her credit, she said, you know what? I'm going to take hold of this. She diet. Lifestyle change more than, if we diet, I'm going to diet for the next 2 weeks. And as a reward, 2 weeks from now, I'm going to go to McDonald's or Chili's. Somebody once told me, a diet is not going to work because it's a short period of time before I go back to the way things were before. It is a lifestyle change. It is a lifestyle change of this is how I'm going to eat. This is how I'm going to exercise. This is how often I'm going to exercise. It is a lifestyle change. To her credit, lifestyle change. And she lowered her A1C from in the 11s down into the 8s. And her visual acuity improved. And her Rabin cone contrast test that we can now measure over time improved from this to that, moving in the right direction, which is critical, moving in the right direction. Her ERG also did that. This was her ERG. And a year later, half a year later, her ERG did that. It's not normal yet. You can still see it's a little bit jagged and we got some low numbers here, but it's moving in the right direction. Functionally, she's moving in the right direction. Her visual acuity went from 20/50 to 20/30 minus, moving in the right direction. And we've got everything moving in the right direction. It didn't happen overnight, didn't happen in one day, but function and structure played a role. 2 last cases. I'm going to tie these together. These are mini cases in my last 4 minutes. 54-year-old Native American female. Pre-diabetic, not diabetic, pre-diabetic. Family history, strong family history of diabetes, but she is not diabetic. Sent in, my vision's not quite as good as it used to be. She's already had cataract surgery. Back of the right eye. Back of the left eye. So back of the right, pre-diabetic. We have not been diagnosed with diabetes as of this point. Back of the right eye, back of the left eye. OCT, and OCT angiogram. There's back to our OCT angiogram. You take a look at that bottom left plot, and I'm seeing more capillary dropout than I would like in this pre-diabetic. pre-diabetic. Look at that capillary dropout in both eyes. ERG, there's the normal example. Here's this patient's. And you take a look at this ERG, overall DR score, 24.8. That is elevated. Ask yourself, as we've read these ERGs, is this ERG more slow or more weak? Is it more slow or is it more weak? And the answer is it is more slow. Those peaks are falling behind where those rectangles, this guidance of where they should fall. They're still decently high. You know, if we moved them to the left, they'd still be in there. So this retina is just not firing. That wiring that Greg talked about is not working like it should. That is not a good sign in this pre-diabetic. Okay. Communicate with the PCP. We requested updated lab testing, and this patient's A1C was 8.4. Is this a pre-diabetic? Nope. This is a patient that you have in your practice that was just diagnosed with diabetes. And based on this, the fundus photos, when would you see this back? And most of us would say within a year. I'll see you back in a year. Last case, tying it with the one we just talked about. Case number 3. 48-year-old Caucasian male, annual diabetic exam. No problems, no complaints, no concerns. He thinks he's doing well. He thinks he's doing well. 16-year diabetic, A1C. My A1C is good, doc. I can eat whatever I want. I'm doing well. He thinks he's doing well. 20/20 in both eyes. Back of the right eye. Back of the left eye. OCT of the right. OCT of the left. OCT angiogram. Ask yourself, better or worse than the case we just talked about, case number 2? Rabin cone contrast test. How's that looking? Looks great. 90 and above is normal. And the ERG. And at the time, this set the record for the best diabetic ERG that I'd ever seen. It's since been broken by a current 4th-year optometry student who's a type 1 diabetic. Look how strong that ERG is. Look how quick that ERG is. A DR score that's normal, looks awesome. We have got great function. We have got great function. We have got a great capillary network. This is much better than the pre-diabetic. You know, so my last question for you is, which diabetic would you be more concerned about? The newly diagnosed diabetic or the 16-year diabetic? The newly diagnosed diabetic or the 16-year diabetic? Generally speaking, we'd be more concerned with the 16, 20-year diabetic, but use structure and function. Use your OCT. Use your OCT angiogram. ERG in this case, you can clearly see the difference. And color vision was better for case number 3 than case number 2 as well. So with that, we are at 8:50. Last question, Greg. Joe, which of the following was not improved by nutritional supplements after 6 months in the DIVFA study? Color vision, contrast, central points in the visual field, or all of that was improved after 6 months of supplementation?
And while the questions or answers are coming in, someone came up with a quick question. I think it'll be an easy one for you to answer. Going back to the DVS formulation, do you recommend 2 pills a day for the vitamin?
2 pills a day for the vitamin. Yes, that is what I recommend. Yep, 2 pills a day with a meal. That is what I recommend.
All right, the polling question's rolling in, and you have 95% saying all of the above were improved after 6 months of supplementation.
When in doubt,
Excellent.
all above, right? Made it an easy one, the last one.
Excellent. All right, Nate. If you'll stop sharing your screen, I will share mine up.
And while that's happening, I want to point out to the audience that if you look on the right-hand side, it says chat polls, course notes, a little red dot says where survey is. You can click on that and start taking the survey. Joe's probably going to show that here with his slides. Nate, if you decide to log off, please don't end the session for us.
I will not do that.
All right. Share my screen. Looks like I lost the PowerPoint when I shifted over. Greg, do you happen to have it available?
I do. I can just open it up here. I should have it.
Oh, I can pull it up. All right. I've got it up. So, Nate, thank you so much for that. That was fantastic. We really appreciate everything you did. I thought you brought electrodiagnostics down to a primary care level. I think a lot of people, myself included, feel a whole lot more comfortable with it. So thank you so much for talking about diabetes, new testing, and treatment for retinopathy.